Afternoon to all. As senior said, today we are going to learn about delirium, which is a common symptom in palliative care, often misdiagnosed. So if the patient is having delirium, we are not able to find out sometimes whether the patient is delirium or not. So this is one of the important topics. This will be taken by Dr. Deepak. He did his MD in community medicine, and also he did a certificate course in pain and palliative medicine from Manipal. And he is having 1 year of experience in palliative care, and now he is working as a palliative care physician here. Dr. Deepak, welcome and over to you.
Thank you so much, Sister Sheba. Very warm afternoon to everyone. Am I audible to everyone? All right, that's good. If you could show your thumbs up, if you could put your videos on, if you could be active on the chat box, it would be great. I certainly hope not this is going to be a one-sided session. I'll be asking some questions. It will be good to have some active feedback, answers, or even interactions as we move along the class. Is that okay with everyone? I can see some of you are walking, some of you are talking. So yeah, so if you could be active on the chat box, it will be great. Or if you could just signal yourself with a thumbs up on the video for those who have your videos on, it will be good. Shall we move ahead with the presentation? Okay, is my screen visible?
Sorry for the interruption. Just wait for 1 minute.
Visible?
Yes.
All right. So I'm hoping that you guys interact in the chat box as much as possible. Can we please have the chat box on as well? So how many of you have seen patients in your setting who seem to be very confused? Either they were normal when they came in, but gradually as the days progresses, they seem very confused. They don't know what they're talking. They don't know where they are. They may ask you random questions. They may give you answers to questions which they were not asked. Have you seen patients like that? Yes, Saloni, yes. Asmita, yes. Others as well. So these kind of patients, we would say that they are in a confused state. So whenever confusion is happening acutely means suddenly it develops in a patient, we can in general call it as delirium. All right. So delirium, the word meaning of delirium itself is, it comes from a Latin word. Okay. And that word meaning is that go out of the normal or go off track. Means they will be normal up to a point. Beyond that point, they will start going off track. That means they start behaving abnormally. And that happens because of confusion, because they are in a certain state of confusion. And this precisely is what we term as something called as delirium. Is everyone with me till now? Okay, I can see Salome interacting with me. Mahima, yes, sir. Okay, that's good. So what is delirium? Like I was saying, it's an acute confusional state. So it is possible that many times we may also be confused about many things. Okay, so certain things in life we may seem confused about. But do we say that we are in delirium? So that's not the state, right? There is an acute confusional state, but when it is associated with a medical condition, this person has an underlying medical condition, or this person is having some form of intoxication. It may be with alcohol or it may be with some other drug, but there is a form of intoxication, or there is a substance withdrawal, that he was taking certain drugs or alcohol and he stopped taking it, and after he stopped taking it he becomes confused. Have you seen people who are on alcohol withdrawal? They would be having alcohol for many years, and then you stop giving them alcohol one fine day and they just become angry. They go to hit people, they may abuse you, they may abuse and hit their own family members, all kinds of issues. So this is what we say, a form of withdrawal is happening. And whenever a person is in a state of withdrawal, at that time as well, there can be delirium. Okay. So in one word, if somebody, in one sentence, if somebody asks you, what is delirium? If somebody asks you, there is only one thing which you have to remember. It's an acute confusional state. Correct? So the person is confused. And did that confusion develop over a period of many days? No. Suddenly he started developing confusion. Okay. Now, even though we say suddenly, okay, we are not meaning to say that in this second he is okay and in the next second he developed confusion. It's not like that. It may develop over a few hours, and in some people it may develop over a period of 2 to 3 days as well. But we are saying acute in terms of those few days, 2 to 3 days or few hours. We are not saying that the person developed confusion over a period of many months or many years, which very often happens in elderly people. Correct? A person is becoming old. When they are becoming old, gradually their brains may start shrinking a little. When the brain starts shrinking a little, they may start developing some forms of confusion, which happens over a period of few months or a few years. So that will be a chronic confusional state. But here we are talking about acute. That means sudden. That means shorter span of time. Are we all together till now? Is everyone able to understand? Does anyone want me to slow down my pace? Is it okay with everyone? If everyone can respond on the chat box. Okay. Okay, Pooja, Shruti, Sister Saloni, Sister Asmita. Okay, that's good. That's good. Okay, so we will move on. So what are the features of delirium? So just like we say prodromal symptoms, that means before a person develops an illness, right? We see many a times, even within ourselves and with our family members, we see that before they develop a fever, for example, I'm just using an example. Before they develop a fever, they will start saying things like, today I am not feeling well. My throat is starting to itch a little. My body is starting to pain a little. So these kind of symptoms, which is very non-specific. Okay, these are called as prodromal symptoms. That is before the illness starts. So there are certain before the onset of delirium symptoms. That is before a person starts exhibiting acute confusional state, there may be certain symptoms. So that symptoms are what? Restless. The person becomes very restless. He will sit at one place, then he will stand up, go somewhere else, sit over there for 2 minutes. He'll stand up from there, go to another chair and sit. He is a very restless person. Secondly, he is a very irritable person. You tell him something, he may just shout at you. He may change his answer multiple times. Basically, he's irritated about something. We don't know what. There is no specific reason as such, but he becomes an irritable person. And third is sleep disturbance. That means the person is unable to sleep well at night. He may be awake at night, or his usual sleep pattern is disturbed. He is sleeping more during daytime, etc. So these are all prodromal symptoms. Okay. Second is a fluctuating course. Fluctuating course means what? Sometimes he will be having delirium. Sometimes he will behave normally. Sometimes he may behave as if he is asleep. Okay. So it is a fluctuating course. That means it keeps going up and down, up and down. It is not always a constant. He is not always confused. Okay. Morning rounds, when you go with the doctor, he may say that he is confused. Evening rounds, when you go with the doctor, the patient is completely normal. And even if you don't give any medication, this is possible that the person keeps fluctuating. He goes up and down, up and down. Okay. Third is disorganized thinking. That means he's not able to think properly. He may talk about he may be talking about the morning food, okay, and suddenly he will start talking about something else, like his mobile phone is not working, or he'll talk about some family issue. He'll completely deviate from the topic which he was talking about. So it's a disorganized thinking. Next is an incoherent speech. Incoherent basically means you're not able to understand what he is talking. He may just be murmuring something, blabbering something, but you're not able to understand it. So it is called as incoherent speech. Next is he has a reduced attention span. So, like we said in disorganized thinking, he may be trying to tell something, but suddenly he will deviate from that and he will tell something else. Or he may just keep quiet and he may just become quiet, mute all of a sudden. So he'll have reduced attention span. So you have to ask him again, yeah, you are telling something, but he's not able to remember what he was talking, and you have to remind him again. So he's got a very reduced attention span. Next is increased or decreased psychomotor activity. Psycho means psychological. Motor means motor activity. That is with the physical body, they are having movements. So they may have increased or decreased psychomotor activity. That means they may be too alert. Okay, one small sound happens, nobody pays attention to it, but he may pay attention to it because he's too aroused, he's too alert right now. And he may have some motor abnormalities. That means he may have some involuntary movements of his hands. For example, he may just be walking somewhere and his hand will just go like this. Okay, some involuntary or abnormal movements of the hands or feet is possible. Next is affective symptoms. Affective means basically what is his mood. Okay, there will be a lot of emotional instability, sadness, anger, fear. Now, when we are talking in terms of palliative care terms, many of our patients will be having some cancer. So whenever such a big illness happens, it's a big shock to them, correct? They don't know what is going to be the treatment course. They don't know how the disease is going to happen. They don't know if their family will be able to take care of them. They don't know if they can take care of their family in the future. So many uncertainties are there. So whenever such underlying diseases are there, the person is obviously going to get affected in some way or the other, right? And in affective symptoms, what we'll see is emotional instability. So when a person is having an acute confusional state, along with that, he's having an underlying disease, he may have a lot of emotional disturbances. He may be having sadness, he may be having aggression, he may have a fear. Okay. So as we were saying, aggression, along with that, there'll be agitation. So agitation means he may really be violent. We don't know how a person with delirium may act out. We really don't know. He may be having hallucinations. So that is called as altered perception. Perception means what a person is able to see or perceive is called as perception. So whenever he's seeing something or hearing something which is not there in reality, okay. Now we have many patients who would say, I feel that I'm lying down here and there are always a group of people standing behind the curtain and watching me. Or there is somebody who is standing behind my bed, besides my bed, and the moment if I fall asleep, I know that person is going to stab me with a knife. These kind of hallucinations may be there. So these are all features of delirium. Okay, but there is one hallmark of delirium, that is attention deficit. Attention deficit means he can't hold on to, he may be talking something, but suddenly he will deviate from that. Completely different topic altogether, or maybe no relation to what he was talking. You ask him something, he may not, that's not what he is responding to. It may be something completely different. So that is basically because of attention deficit. Okay, so that is the hallmark of delirium. Is everyone with me till now? Do you guys have any doubts to ask? Any confusion? Anybody going into delirium right now, listening to all this? If you could respond on the chat box. Okay, is everyone able to follow? Only Mahima has responded. Yeah. Yes, Sister Sunita, Rekha, Shruti, Shikha. Okay, that's good. That's good. So then we'll move on. Okay. So what are the causes? As you can see here, the word delirium itself we have used as a mnemonic so that it is easy to remember. So one is drugs. There are a lot of drugs which themselves can cause delirium. Eyes and ears. That means what do eyes and ears help for? They help in perception, right? They help in perceiving what is happening outside. So if suppose there is less stimulation from the outside world, the person is tend to become confused. Okay. We have seen many times in ICUs. How many of you work in ICUs? Any of you who are working as an ICU nurse? If you could raise your hand or put on the chat box. ICU, exposure to ICU settings. So there you will see that many a times there are people who are in confused states. So you ask them where they are, they may tell something else. They may not know what the time is. So many issues. So the reason is always inside the ICU, the lights are on, the monitors are beeping, right? The person is having the same stimulation all the time. So tends to get confused. Other thing is for elderly people, they may not, they may be having a vision problem, because they have power in their eyes, so they don't have a spectacle, or they are not able to hear properly, so they need a hearing aid. So basically, is they are deprived of, they don't get enough visual or auditory stimulation. So when that happens, they tend to become confused over a period of time. Will all of us become confused if we get less oxygen? Any doubts on that? So all of us will feel confused if we have low oxygen. So exactly what we are talking about is any stroke which is happening, either a stroke which happens in the brain or an infarction which happens in the heart. Both these situations where blood oxygen is supposed to go, or where blood is supposed to take oxygen and go, it is not able to reach. When that happens, it becomes a low oxygen state, and that time we may go into acute confusional state. When we go into acute confusional state, we say that we are in delirium. Okay, as simple as that. Infection anywhere in the body, once it becomes extensive enough, or once it becomes severe enough, it can spread through the blood to other parts of the body. Once that happens, there can be worsening of delirium or new onset of delirium. R stands for retention, that is either urinary retention or retention of stools, that is urinary retention or constipation. Any of these can precipitate delirium. Ictal means seizures. So ictal means seizures or fits disorders. Once the person gets fits, have you seen people who have got fits? Immediately after they get fits, once they are back to their normal senses, they may be many a times confused. They don't know what is happening around them. Okay. So this post-ictal states of confusion, that can also cause delirium. In our settings, palliative care settings, very important cause stands for U, uncontrolled pain. Uncontrolled pain is one of the things which we very, very frequently come across, especially in palliative care settings. Majority of the patients who get referred to palliative care is for pain management, correct? So uncontrolled pain can itself cause delirium. So a person who is having some illness which is causing severe pain, the one thing which we have to address is to take care of the pain rather than going for some other investigation in that patient. M is metabolic. So many of you would have seen whenever the sodium levels, potassium levels, magnesium levels, calcium levels go up and down, there can be behavioral changes in a person. So these things themselves can cause delirium. So metabolic cause of delirium. And S is subdural hematomas, that is within the skull. Within the skull, if there is a collection of blood due to whatever reason, due to an injury or due to old age, if there is a collection of blood, it will compress upon the brain matter. It will compress upon the structure of the brain. So the brain is not able to function the way it should have functioned, and it will cause confusion in the person. Okay, so these are all the causes of delirium. If you look into some textbooks, there is anywhere between 30 to 50 causes of delirium. But we have just, for sake of understanding and for easy recollection, we have made it into this format. Is it okay till now? If you could come on the chat box and respond. Is everyone able to follow till now? Okay. Anybody having language issue or is not able to understand? If you want me to explain or say in some other language, I can manage 3 or 4 languages. Of course, not languages of other countries, but within India. I see majority of you are Indians. That's why. If you want me to speak in Hindi or something. Okay, okay. I think everyone is comfortable. Fine. That's good. So shall we move on then? Right. So you can see this is just a statistic for you. In about 30% of the patients who are hospitalized, they may have delirium. And patients who are close to end of life, that is, they're nearing their passing away. Okay, they're nearing their passing away. 85% of those patients will have delirium. So in especially in palliative care settings, you would see that many of the people are near end of life, or they may come to you during that time because the family is unable to manage them. They are showing aggression, they are showing confusion, they are having a behavioral abnormality. All these things are there. So the family may become overwhelmed. The family may not be able to help them, help the patient. So they may come to you. At that time, we have to do something to make the patient calm, make the patient as sensible as possible, so that the patient himself or herself and the family members both can be at peace and spend some quality time with each other. So burden of delirium 30% in hospitalized patients and about 85% in those nearing end of life. So what is the impact of delirium? So one thing is, so you will see many a times when there are elderly people, okay, there are elderly people, they have a functional decline. That means day-to-day activities of living which they used to do, they are unable to do. Okay, why? Because their mobility has become less. They are not. They are lesser mobile. They tend to sit more. They tend to lie down more and sleep more. So that is called as a functional decline. Now, when they have to get up in between to go to the washroom or go to the kitchen or just walk around somewhere, they have a tendency to fall due to many reasons. One thing is they may have muscular weakness, they may have bone problems, right? So they have a tendency to fall. Now, once they fall, their bones have become weak because they are old, and that will cause a fracture. Now, what is the first thing which we tell when there is a fracture? Please don't move, right? We tell them don't move. So you have to stay, you have to take rest for 1 month, 2 months, or 3 months, depending on what kind of a fracture it is. So basically, we immobilize the patient. And once we immobilize an elderly person, that is their decline. That is the beginning of their decline. Okay. So one thing is in a delirium, when they are in an acute confusional state, the tendency for them to have falls and fractures is more. So once they go into falls and fractures, it is a vicious cycle. That means they will only go down and worsen over a period of time. Next is incontinence. They may have behavioral abnormalities because they are in an confused state, right? So they may have urinary. One thing is retention, that is one thing, but they may have incontinence as well. Okay, that is, they may pass without knowing or without telling. They may pass urine or even feces. Hydration and nutrition. We already told that if there are a lot of other factors which can cause delirium. So do you think a person who is confused in his mind may think that, oh, I am feeling thirsty, I need to drink water now. I've not eaten enough food, or my sodium levels are low, I need to take enough in nutrition. Will they do that? They won't, right? So they tend to not take care of themselves also. So it is one of the impacts of delirium, that their hydration and nutrition will suffer. Next is emotional burden. They may themselves feel emotionally, one thing, the family feels emotionally burdened, that their loved one who was there with them in a normal state till yesterday, today he is behaving weird, today he is shouting abuses, Today he is telling that he is going to hit me. Or another kind of delirium in which the person becomes depressed, not talking, is not interested in whatever is happening in their surrounding. So it gives a big emotional burden to the family to keep watching this. Okay, that why somebody whom I love has become like this. So it becomes an emotional burden. Not just that, even the patient himself will start feeling, himself or herself, that they are becoming a burden for the family, that they know that they are not able to manage themselves, they are having issues, and the family is having a difficult time handling them. So it becomes an emotional burden in both ways. So this is just as to why does delirium happen. Okay, so one thing is the pathophysiology is very poorly understood. It is not completely known to us that what is the exact mechanism as to why there is delirium happening in a person. But there are certain theories which says that the basically whatever happens within our brain, okay, is a chemical. It has got chemical basis to it. That is, between two nerves and between each nerve there is a chemical which is passed, which we call as neurotransmitter, right? So whenever these chemical exchanges happen, there has to be sufficient amount of chemical for the message to be passed normally. So some of these are called as neurotransmitters, are called as acetylcholine. You must have heard of acetylcholine, or dopamine during our training days. So there is something called acetylcholine, there is something called dopamine, there are other neurotransmitters as well. Whenever there is an imbalance between these neurotransmitters, that is when a person develops delirium. Remember one thing, one term I'll tell is whenever for us to function normally, everything within our system should be in equilibrium. Equilibrium means they are all balanced well, and the system knows how to balance. But due to some other issue, like the delirium, the causes which we looked at, DERILIUM and S, due to those external factors, there will be a disturbance in this equilibrium, and that causes delirium. But let me ask you something. Do you think that everybody who is exposed to some form of the cause, the delirium cause, they will develop signs of delirium? Everybody, will they develop equally? So there is a difference in this. Okay, so not all individuals exposed to the same insult will develop signs of delirium. Let's have a look at it. Here you can see that there is just one second. Laser. Yeah. So here you can see on this side there are individual risk factors. Okay, these are individual risk factors, and these are certain triggering factors. What do individual risk factors mean? Means in a person, the person is too old, or the person is too young, the person has some chronic diseases. Since many years he is having some disease, maybe diabetes, maybe hypertension, maybe cholesterol issues, maybe a kidney disease, maybe it is some form of cancer. Okay, so many chronic illnesses, whether he has or not, these are all individual risk factors. And there are certain triggering factors. Trigger means something which causes the start. Okay, something which is the starting point. So it can be an infection. Okay, it can be a surgical procedure, or it can be some drugs which he has started taking recently. Okay, drug need not be illegal drug, I mean medications as well. Okay, so see, whenever the individual risk factors are low, that means the person is not having, he's a young age. Okay, he's of young age, he doesn't have dementia. Dementia means some problem with the he is not in a confused state chronically. Okay, so he's not having any memory problems as well. He doesn't have any chronic diseases. Such a person, do you expect to get delirium easily? No. See, I am a young person, for example. If I get an infection, I may not go into delirium. Okay, I may be able to handle it well. Okay, but suppose I develop some serious infection and it has spread throughout my blood. Whenever an infection spreads throughout the blood, we call it as sepsis. Okay. Or I underwent a surgical procedure, a very high risk surgical procedure on my brain. Okay. Or I started taking some new medication on a high dose. Now, even a person, healthy young person like me, is prone to develop delirium. So that is what this means, that even if a person's individual risk factors is low, for that such a person to develop delirium, the triggering factors should be high. Okay, the triggering factors has to be high. But if a person is old, if the person is having some memory issues, the person has been having some chronic disease for 10-20 years, for such a person in whom the individual risk factors is high, even a small triggering factor is enough for him to develop delirium. Is this point clear to everyone? For a person who has low individual risk factors, he may need something big to happen to him for developing delirium. I want you all to respond on the chat box. And for a person who is having high individual risk factors, who is elderly, who is having other illnesses, for such a person, even something small, a small triggering factor is enough for developing delirium. It can be as small as changing of the room. I'm just giving an example. You put the person, you built, you out of love for your elderly person at home, you built a new house for them and you gave them a new room with all amenities and luxuries in it. And the person enters that room and he becomes confused. Reason is he has been having certain other issues. Along with that, there is a small triggering factor that he is in unfamiliar surrounding. That itself can be a cause of delirium. Okay, so we will move on. So, what all are the states when delirium threshold is lower? Threshold means how much of insult is beyond what point will that person develop delirium. So, like we said, if it is extremes of age group, elderly person needs only something small to happen. So, low threshold. If the person has memory issues, dementia, the person can easily develop delirium. If the person is having visual or hearing impairment, right? We had told ears and eyes under that E of delirium. So if the person has hearing or visual impairment, then the person can easily develop delirium. If the person is a chronic user of alcohol, alcoholics are otherwise itself in a confused state most of the time. So if the person is having alcohol abuse, in such patients, delirium threshold is lower. If the person is having some form of depression, delirium can happen easily. And like we said in elderly, if there is reduced physical activity, then also it's easy for developing delirium. This is what I was telling. Triggering factors. What can trigger delirium? How can a delirium start off? Even something as simple as a change in environment. That is why we say that people who are prone for such situations should have their surroundings as familiar as possible. The same room setting. For example, they may be seeing that there is a flower vase sitting on the right side, right corner of their room. If they see that, always that should be there. Okay. If they don't see it on one fine day, they may get confused. Where am I sitting? They have a television set right on one of the walls. They come to a new room, it is not there. They will start getting confused about it. Okay. Unfamiliar excessive stimuli, too much of loud noise is happening somewhere, they are not familiar with it. For example, ICUs. As we were telling, in ICUs, always there is loud sounds happening from so many monitors, right? These are all monitoring devices, helpful for the medical team, but annoying to the patient. So unfamiliar excessive stimuli, too much of light on all the time, too much of sounds happening all the time. Do you think a person can sleep in such a circumstance? Definitely not, right? General deterioration, if their general condition is becoming poorer or weaker, and any of the uncontrolled symptoms. The example which we told is uncontrolled pain. That is one thing. Other thing is if they have some other, like their infection is not being controlled, okay, or their blood sugars are not being controlled. If their sodium levels have come too down or too up, okay, etc. In such situations also, it can be a trigger. Definitely brain tumors, okay, primary or secondary, anything happening within the brain. Some place the brain should be there and functioning, but along with that, now a tumor or a cancerous growth has happened and it is occupying a space within the brain. So the brain is getting compressed, or whatever function that part of the brain was doing has been lost because over there right now the tumor is sitting. So the person goes into delirium. Neoplastic means cancerous. Okay. So along with the cancer, there are many biochemical abnormalities which can happen because every cancer has got a characteristic of its own, and they will start showing these characteristics through the patient. So paraneoplastic syndrome. Para means along with the cancer. Para is along. Neoplastic means cancer. So along with the cancer, there are certain syndrome. Syndrome means different kinds of issues which can happen. So it is a all of them together we call it as syndrome. So paraneoplastic syndrome, biochemical disturbances we already said, and drug induced. That means if they are having some kind of medication which can alter the levels of the neurotransmitters in the brain, right? We told that this is because of neurotransmitter issues, chemical imbalance happening, right? In Hindi we say chemical locha jab dimag mein hota hai. So when we say like that, that is what where drugs can cause that, medications can cause that, correct? So in such situations also it can be a factor to trigger delirium. Withdrawal states, like they were using some form of drug or alcohol and they have stopped it and they are in withdrawal. Organ impairment, your liver, your kidney are two good examples where they handle a lot of toxic elements in the system. They purify the blood. They make sure that toxic substances, liver deals with toxic substances. The kidneys make sure that your biochemical parameters of sodium, potassium, and all is balanced, and your urine is being produced. Now, if suppose there is some organ impairment, all these toxins will start staying within the body, inside the blood, circulating everywhere, including the brain. When that starts happening, the person is going to there will be chemical imbalance again, and the person will go in for delirium. Sleep deprivation. Any of us, if we go into sleep deprivation, you know how confused we can be. So a person who is having a disease and along with the disease, that person goes into sleep deprivation, it is going to worsen the delirium for him. Next is surgeries, any major surgeries, neurosurgical procedures, or surgeries leading to certain infections. All this can cause delirium. And trauma. Trauma would mean some accident which happened. Somewhere I fell down on the road, hit my head. There is a trauma. Now there is blood inside my skull. I can go into delirium. So trauma. Right. So that brings us to what are the types of delirium? So basically there are three types. One is hyperactive delirium. As you can understand from the term, the person is very hyper, okay, very overactive, very aggressive, very agitated, very restless. So a person is hyperactive. Okay. Second is hypoactive. That means he is not talking as usual. He is not interested in watching his favorite movie as usual. He just likes to keep quiet. He's looking somewhere else. His family is talking to him. The doctors are talking to him, but he's not interested. He's not attentive also. He's looking somewhere else and lost in his own thoughts. So hypoactive. And then there is something called mixed. That is a type of both. What kind of patient would you prefer if you could come on the chat box? You want a hyperactive person or a hypoactive person as a patient? Let's see. Okay. Hypoactive. So you want to say that even if your patient is abnormally quiet, it's fine with you? Is that what you mean to say? Okay, Sunita, Sister Sunita would like mixed. Okay. Okay, so let me just clarify this. We don't want our patient to be in any kind of delirium. That is one. One is hyperactive. It is very easy to detect, right? Because the person is going to threaten you. Most of the times, either going to threaten you or the caregiver or himself or herself. Because they are a threat, we have to pay attention to them. But a person who is hypoactive, we may feel, oh, it is good. This patient is not causing us any problems. We are also able to sleep at night. They are also sleeping at night. No need to bother them. Let them just be. Now, the problem with hypoactive delirium is the person, as the disease, whatever is the underlying disease, as it progresses, the delirium which they may tend to develop later on is going to be much worse, is going to be very bad. And because of that, it will cause severe distress to the patient as well as to the caregiver. For this one reason, we have to ensure, especially as nursing staff, that we have to ensure that we always observe if a patient is going into hypoactive delirium. Hypoactivity may be okay, but is he going into delirium? That is something which we need to ask. Many often in conventional places wherever we are working, usual states, the doctor may spend anywhere between 2 to 5 minutes for a patient. Okay. Especially in a country like India, where we have such a huge patient load, a lot of numbers, we may not get that much time to spend with the patient, the doctors. So the nursing staff often ends up spending much more time than the doctors, correct? So when that happens, you are the ones who are supposed to observe that, oh, this patient is abnormal a bit today. He is quiet, but this is not normal quiet. Okay. So then you have to assess whether this person is having delirium or not. So this is what it is. So you can see over here, this is more agitated, and here it is withdrawn. Withdrawn means he is quiet and is in his own world. So this is what we mean by a fluctuating course. We said one of the characteristics of delirium is fluctuation. That is ups and downs keep happening. So this is what it is. This pink line is the baseline. Okay, pink line is a baseline. And this green line is what the patient state is. Sometimes he's becoming angry, agitated, restless, and then sometimes he will become normal. After he becomes normal, sometimes he'll go into depression. He's not interested to talk to anyone. His best friend calls him, he's not interested. You're showing him his favorite movie, he's not interested. Again, he will become normal. Again, he will become angry. And this is what is called as a fluctuating course. When these both starts happening, we call it as a mixed delirium. Okay, we call it as a mixed delirium. Right. So how do you assess? So we said that whether a person is in hyperactive delirium, you can easily see. But when a person is hypoactive delirium, it may take some time to assess this person, whether this person is having an acute confusional state or not. So there are many assessment tools. Okay, tool is something which we use, right? So there are many assessment tools which we can use to understand if a person is in delirium or not. We won't be looking at all of them. I've just listed some of them over here. We'll look at only 2 of them. Out of those 2, we'll look at one in a little elaborately. That is called as Confusion Assessment Method, or CAM. So there are 4 primary things which Confusion Assessment Method looks at. Is it acute onset and a fluctuating course? Is there inattention? Is there disorganized thinking? And is there an altered level of consciousness? Let's look at this. Acute onset and fluctuating course. That is, the person is being confused. He is thinking that he or she is not in a hospital. You are seeing this patient in a hospital and you ask them, where are you? And he will say, I'm at my sister's home. Okay. And he may say things like we were saying, I may have hallucinations. That, oh, there is a group of people who are standing here. Somebody is hiding beneath my bed. There is a bad smell coming here all the time, which may not be true. So they are seeing things that are not really there. Next is inattention. Inattention means we want to check how much is their attention. Are they having normal attention or not? So there are 2-3 ways of doing it. One thing is digital span. So you tell them a number, maybe 2, 4, 5, 6. Okay. And you ask them, can you repeat 2, 4, 5, 6 backwards? Okay. Can you all repeat 2, 4, 5, 6 backwards? Not as 2, 4, 5, 6. You have to say 6, 5, 4, 2. Like that. So same way, you will tell some number to the patient, right? Now you have to tell that, and you have to ask the patient to repeat it backwards. So person needs to have a normal sense of attention to be able to do that. Next is you can ask him to say what are the days in a week, but backwards. Instead of Sunday, Monday, Tuesday, you will tell that person to say Sunday, Saturday, Friday, Thursday, like that, backwards. Or is he able to say the months in a year backwards? That is from December to January. Are all of you able to say this? Anyone in delirium right now? I just want to assess. It is afternoon over here in India. Majority of you are in post-lunch session, and maybe hyperglycemia can also cause delirium. We want to check. Can all of you repeat it backwards within yourself? Can I see some thumbs up for those whose videos are on? Okay, Sister Simi Thomas, Sister Shikha, can I see some thumbs up? Okay, that's good. That's good. So that is inattention. Next is disorganized thinking. So disorganized thinking, we need to know that. We'll ask that, which is the current year? Which year is going on? Are they still in 2022 or are they in 1980s or something like that? Okay, which is the current year? Which day of the week is it? Where are you right now? These are simple questions which you can ask for understanding if the person is having disorganized thinking. Next is altered level of consciousness. Like we said, the patient may be in hyperactive delirium or in hypoactive delirium. So in what state is he? Is he too alert? Like we were saying, right? He notices every small thing which is going on. Any movement, the curtain moves because the fan is on and the person is like, there is somebody hiding behind. Is he too alert? Is he too vigilant? Or is he lethargic, stuporous, as in very less movements of his body, not less much of talking, or sometimes maybe even comatose? Is he going into comatose state? Is he going into coma and coming back? So altered levels of consciousness. So this is what basically we need to understand from CAM. Okay, confusion assessment method, acute onset and fluctuating course, inattention is there or not, disorganized thinking, and altered level of consciousness. Now this is just for your knowledge. There is another simple method which is called as the 480 method. So this is called as assessment test for delirium and cognitive impairment. The same things we will check for. Okay, the same things we will check for, and we will be giving certain scoring to it. Like we'll give marks 1, 2, 3, 4, 5, 6 marks we'll give to them. And if the mark is above 4 or above, that means the person is in delirium. So when you get the slides, you can look into it. It's pretty self-explanatory. Now, how do we manage delirium? So the first rule always is you correct what is correctable. Okay, so you have to find out what the cause of the delirium is. First, you have to narrow it down, and then you have to see whether that cause is correctable or not. Many a times it may be due to a drug or a medication which the person is taking. Now we can see that, okay, we have to bring down the dose of something, or to counter that effect, we have to give some new drug or something like that. But sometimes we may see that there is a big brain tumor, which we can't do anything about. So we can't correct it, right? So whatever is correctable, first you try correcting it. Sodium levels are down, correct it. Oxygen levels are down, correct it. Okay, glucose levels are down, correct it. Some medication is going in an overdose, reduce it, right? So these are all correctable factors. So you correct the correctable. Second is pharmacological methods. Second is non-pharmacological methods. That means this is where very important role of nurses comes in, or paramedical staff comes in. Okay, that there are many non-pharmacological methods which we can do. So you all will come across it. We'll look at it in a little bit detail and see how you can contribute. And then finally, we will use pharmacological methods. Pharmacological method means for the delirium, we know there is a chemical imbalance which is happening. And for that chemical imbalance to come back to a normal state, we will give them some small medication in a small dose so that that chemical imbalance is taken care of and the person becomes normal again. Right. So correcting the correctable, we have already looked at. Now, what are the non-pharmacological things, okay, which we can do? So as you can see over here, optimize sleep-wake pattern. We told that there is a these people can be sleep deprived, or because of certain issues, they are not able to sleep well. Okay. So we have to optimize. Optimize means we have to make it as ideal as possible, as normal as possible. When do we want them to sleep? Do we want them to sleep during daytime or during nighttime? You can come to the chat box and respond. When do you want your patients to sleep? During daytime or during nighttime? Okay, there is no confusion on that. At least for the sake of the caregiver, we have to ensure that the person is sleeping at night time itself, right? Second is patient orientation. Is the patient oriented enough? Where is he right now? What is he doing? What is he doing in a hospital? Who is the person who is sitting to take care of him right now? Third is communication. Fourth is encourage mobility. Five is monitor the person's hydration and nutrition. Sixth is monitoring the bowel and bladder function, because we said that even retention of urine and feces can cause delirium, and provide support and education to the family. We look into each one of them. So optimize sleep wake pattern. One of the things we know for sure is whenever there is too much light, it is difficult to sleep, right? So what do? We have to ensure that during the daytime, they have maximum exposure to sunlight as possible. So what we do over here in our setting is whenever there is a person who is in delirium having sleep issues, we tell them, give them a bed which is closer to the window, directly facing the window. So when that happens, they are able to see that it is daytime, or there is too much brightness. Maybe it is afternoon. Now the sun is setting. Now it is dark. It is night. Correct. So increase daytime in exposure to sunlight. In a sense, ensuring that they are having a bed positioned in such a way that they can see the window, okay, or they can see they're right outside near the window. Next is low level of light and noise. When they are going to sleep at night, ensure that there is low level of light and noise, even if they are in a ward. Many a times we have seen that the nurses will end up talking to keep themselves awake, right? A nurse is having a night duty. They have to stay awake till morning. It's not an easy job, right? So to keep themselves awake, they may end up chit-chatting or talking with each other. No problem. But what will happen is the patient gets disturbed. And if you have a patient who is having delirium in your ward, it is going to be much more distressing for the patient. So ensure that there is low level of light and noise. Third is certain sleep protocols. Now, patients may prefer something like, somebody may say that you just massage my leg and give. You have seen sometimes our parents tell us they'll put their legs on our laps and we are supposed to massage with oil and give at night, okay, or give them a head massage. Or something like that. Some people, if you give them warm milk, it helps to, it's a routine which will help to make them sleep easily. So maintain certain sleep protocols which helps the patient to fall asleep. Okay, so this is what we mean by sleep protocols. Next is patient orientation. You have to repeatedly reorient the person. Okay, where is he? Who is he? Who is with him? Why has he come here? What are we doing to him? Who are you? All these things you have to continuously reorient the patient on a day-to-day basis. Other thing is they can have a whiteboard and a visible clock. So whenever there is a visible clock, they know what the time is. Many a times they may not be having a clock near them, so they are confused about what the time is. Other thing is you can have these things written on a whiteboard. You can have a whiteboard near the patient, and on that it is written where they are, okay, who is with them, what their name is, etc. Things like this, which the patient is confused about, which you have to reorient them about again and again. Those things you can write down in whiteboard. Can any of you tell me that what is that famous Indian movie in which a person had to write down things to remember? There are many North Indians over here. I'm not sure if there is an English movie or an other movies of other languages which have the same thing. Yeah, Gajni. Okay, the Gajni is the name of a guy. So he used to keep forgetting things after he got a trauma. Okay, you remember he got a trauma to his head. We told that one of the triggering factors can be trauma. So what happened to this guy is somebody hit him on his head and he got a trauma. After which you can see the scar on his head. After which he started developing. He was having memory loss basically. So he had to reorient himself again and again. So what did he do? He wrote all these things on his own body. And whenever he'll see himself in the mirror, he starts remembering what it is, what is his purpose and who he is, and all those things will come back to him. So this is exactly what we mean by reorienting the person. Communication basically we mean is good sensory stimulation. Ensure that a person who is having visual difficulty is having an eyeglass with the correct power. Ensure a person who is having hearing difficulty is having hearing aid. A person who is not able to chew well will have difficulty and distress because of it. So use of dentures. Okay. So they should have good communication. Others encourage mobility as much as possible. We don't want a person to be stationary at one place. Encourage the person, even if they're elderly, to whatever extent possible to start moving around. Okay. Sit out of the bed for meals if possible. Anyways, if even if the patient is lying down, many a times it is possible that they're at least able to sit up, or to prevent aspiration or movement of food into the lungs, you want them to sit up a little bit. So ask them to, if possible, sit up, or give them a chair and a table to eat, this sort of thing. Okay, so sit out of bed for meals if possible. Do you like being physically restrained? Your hands and legs being tied to anywhere? Do you like it? Anyone? In general, no. Okay, in general, no. So it is going to be irritating for anybody if you tie their hands and legs. They just want to maybe take their hand and scratch their head, and you have tied their hand to the railing of the bed. Right? Very commonly seen in wards. If the patient has become difficult to handle, just tie their hands and legs. It is going to worsen the delirium. Already the person is having irritability in delirium. On top of that, you want to further irritate the patient by tying his hands and legs. It is not going to do well for the patient. Lastly, minimize the use of catheters, because one thing is catheters can cause infection, and that itself can cause delirium. Other thing is it will restrict mobility. Just imagine having a tube down, and then you have to carry the Euro bag with you wherever you have to turn. So a person who is in a vulnerable state like this may not be able to do all these things. So he will just choose to stay immobile or sit or lie down at one place. So minimize the use of catheters. Monitor the bowel and bladder function. Assess if there is urinary retention. If there is urinary retention, ensure that the urine is being drained. If there is constipation, it can worsen the delirium. It will worsen the delirium rather. So make sure that there is no constipation or fecal impaction. Give enema, do what is required, and if required, do manual evacuation, but ensure that person is not constipated. So monitor bowel and bladder function. Next is involve the family. Ideally, in every medical setting, we need to involve the family, see what is their current state of mind, what they are going through, and give them that motivation, support, and education that what the patient is going through, why the patient is going through something. Okay, if you are able to explain to them, at least to some extent, why a person is behaving the way they are behaving, it can reduce some distress for them. Already it is difficult for them to understand what the patient is going through. On top of that, they will be feeling bad that whatever they do, it is not helping the person. Right? So on top of which we don't communicate with them properly. We spend only maybe 2 to 3 minutes or 2 to 5 minutes with the patient and look at them. Okay, your glucose levels are up, your this levels is down, and we'll use some medical technical terms which is difficult to understand for anyone, and then we'll say, okay, we'll see tomorrow, and go. Now in all these states, the patient is anyways in delirium. Slowly we'll ensure that the caregiver also goes into delirium. So that can be avoided by giving proper education and support, right? So you have to tell them what the patient is going through, why they are going through it. Don't worry, we are going to give them some medication. Don't worry, why don't you reorient the patient? Whenever you have time, you talk to your loved one and say that where they are, why they are here, what treatment is going on over here. Talk to them about some of their old memories which they like revisiting. Okay, maybe it may be about their marriage. I don't know, that is questionable, but or something else, some pleasant memory which they want, okay, which they want to revisit, something like that to reorient them, right? So you need to take the support of the family in the treatment of the patient as well. That is what I'm trying to say. So involve the family, educate them that what the patient is going through and what they can do non-pharmacologically to ensure that the patient starts improving. And ask them to reassure the patient in a calm voice. Many a times, if you have an aggressive person at home, one day we'll feel sad. Second day, we'll try doing what we can do. Third day, we'll also be angry, correct? We'll also be like, what, just shut up and sit somewhere. We may end up saying like that. It is understandable. It is understandable because the family members also go through a huge level of burden. They have to do all the work at their home, or they have to do their normal day jobs, or they have to do their usual routine, whatever they do. And along with that, now they have to take care of a patient who is not able to manage himself. So it is going to be very difficult for them. So ensure that you handhold the patient always, and the bystander, and the caregiver. Okay. Are we together till now? Come on the chat box. Are we together till now? Everyone. Okay. Now coming to pharmacological management, we won't be going too much in depth because this is more relevant for the doctors who will be deciding when to start a medicine for delirium and how much to start it for. However, for your knowledge, I want you to know the names of it. Now, there are 4 situations where you want to give a medicine. One, non-pharmacological methods. That means you tried everything from your side, non-pharmacologically, but nothing is working. The patient is still having delirium. And on top of that, what is happening is this patient is distressed. He is having hallucinations because of which he is missing his sleep. He doesn't feel like eating. He doesn't feel like talking, or he is not doing all this. He is doing all this totally abnormally. So the patient is distressed. Okay. Thirdly, a patient is a risk to themselves or to others. They are lying down in your ward. If it is an aggressive patient, they may take the steel tumbler, steel glass besides them and hit them on their head, or they may throw it onto the caregiver or to the patient who is lying besides them. So the patient is a risk to themselves or to others. And fourth, he is agitated. That means he is angry. He can be violent anytime. If these 4 situations are there, and if non-pharmacological has failed, then we will be giving some medicine to ensure that the delirium comes down. So basically, it is to target 2 symptoms. One is agitation. Second is perceptual disturbance, that he is feeling he is hallucinating. Okay, he is hallucinating and he's thinking that there are a group of people here to hurt him or something like that. Perceptual disturbance and agitation. It is targeting these 2 symptoms that we want to give some medication for delirium. So which is what the class of medications which we give them is called as antipsychotics. Okay, psychotic means that they are going into an abnormal behavior, right? And what we'll be giving them is antipsychotic, that is something against the psychosis. And the drug of choice for this is haloperidol. Now, haloperidol is a grade 1 antihypertensive, is a first generation antipsychotic. Then there are certain second generation, little bit more advanced medications. These medications, if you give, they will develop some sleep also. We said that there are many of these delirious patients, they won't be sleeping well at night. So we want them to sleep well at night. At the same time, we want their delirium to come down. So there are certain second generation antipsychotics. These are the names: quetiapine, risperidone, aripiprazole. Okay. So these are certain names which you can remember: haloperidol, quetiapine, risperidone, aripiprazole. And lastly, there is something called benzodiazepine. Usually when you give benzodiazepine, I'm sure if any of you have transported agitated patients for taking an MRI or a CT scan, okay, you want to make the patient calm or immobile for some time. So you will give either midazolam or lorazepam. So these are medications which we can give if the patient is very agitated. Hyperactive delirium means he is too hyper. You are not able to control with usual medication. Now you want the patient to rest physically. Now you give him a midazolam or a lorazepam with which the patient will settle. Okay, it is a benzodiazepine, not used routinely, but only used when there is hyperactive delirium. So what are the conclusions? One thing is always correct the correctable, because now we saw that there are many people who are many causes which can be corrected. So always correct the correctable, right? Go for non-pharmacological managements as far as possible. Many a times that's all the patient needs. Sister Asmita is trying to talk something. I think you can unmute yourself and talk. So go for non-pharmacological management as far as possible. Okay. Second is a multidisciplinary approach may be needed. That means we may need a specialist opinion many a times, right? We may have to take consultation from some other specialist to see that how to go about treatment for some specific issue. So multidisciplinary approach may be needed. Next is always communicate and take the caregivers along, because it is not just the patient who is in suffering, it is the caregivers as well, right? And lastly, identify hypoactive delirium and start medications for it as well, because a person who is in hypoactive delirium may be very convenient for us, but the person will develop a worse form of delirium which will be very distressing for the patient and the caregivers later on. So even though the patient is hypoactive, don't think that this is good for us. Let the patient be like that. No, you have to look at it, assess using the CAM method, confusion assessment method, and see if the patient is in delirium, and if so, you have to bring it to the notice of the doctor who can start a medication. Right. So that brings an end to the theoretical part of it. Now you may please, if you have any doubts, feel free to unmute yourself or use the chat box. There was one question which was asked earlier on, which asked that if a person is in a family, is in a stressful situation in a family, and we forget things, is that delirium? Like we said in the definition of delirium itself, that if there is an underlying medical condition, or the person is having a substance problem, or if the person is withdrawal, if along with your family stress, a family stress can be a triggering factor, correct? We told there are triggering factors. If a family stress can be a triggering factor, but as long as the person doesn't have a confusional state due to an underlying disorder or a substance abuse or withdrawal, we won't consider it as delirium. If anyone has doubts, you can please feel free to unmute yourself or use the chat box. So what we were telling about restraint is simple question I was asking. Do you like to be restrained? Do you like your hands or legs to be tied? The simple answer is no. So in such a situation, a person who is in delirium, already he may be irritable, restless, agitated. If along with that, if you tie his hand as well, just imagine what situation that patient is going to be in. Much, much more distressed, correct? So what we need to address is that why that delirium is happening and can it be corrected? That is what we need to address. If the patient is agitated, okay, we are thinking that he may be in hyperactive delirium. That is, he's become too agitated, too hyper. In those circumstances, like we said, along with the antipsychotics, we can give a small dose of benzodiazepine with which the patient will become calm. So when we know the person was drinking alcohol regularly, we then use lorazepam right from the beginning. We should not. Ideally, there is a method to wean off a person from alcohol. You have to give them some form of therapy, okay, which is done by a psychiatrist. So you should refer the patient to a psychiatrist and ensure that they will take the course of treatment. It is not just with a drug, but there is a course of treatment which they go through. And mostly the patient will require admission for a few weeks, from a few days to a few weeks. So that is how that approach should be. So if anyone wants to just unmute yourself and ask any questions, that is also fine with me. Yes, Sister Sia, have you unmuted yourself? Sister Sia?
Yes, sir.
Yeah, do you have any questions? Thank you, Dr. Deepak, for the excellent presentation.
Thank you, Sister Shiva. I think that there are no further questions and maybe we can go ahead with the case presentation. Is that okay, Sister Shiva?
Yes, yes, we can move on to the case presentation. Sister Sia will be presenting a patient story today. So, kindly put off your fan there, Sister Sia.
We are just loading the presentation, just a moment.
Yes. Sister Sia, can you hear us?
Sister Sia, you are muted. Can you please unmute yourself? Yeah, you may please proceed.
Good evening to all. I am Ms. Sia Devi, staff nurse in Harbatpur Christian Hospital, one of the EHA unit. So I am going to case presentation. The patient age is 54 years and gender is male. Diagnosis is bilateral grantor trochanteric ulcer with chronic bedsore stage 4 and right hemiparesis 2010, left hemiparesis 2005. Presenting complaint was bedsore over the right and left trochanteric area, gluteal region, having throbbing pain, severe headache, loss of appetite, insomnia, constipation, and hypotension. History of illness is Mr. Kumar Pal has history of large bedsore over the right greater trochanteric area extending to the back since 7 days. He is known case of CVA with left-sided of hemiparesis in 2005 and right-sided of hemiparesis in 2010. He was on bed rest. Examination was conscious, temperature 101 Fahrenheit, pulse rate 100 beats per minute, respiration 20 beats per minute, and BP was 90/60 mm of SG. Treatment and significant investigation. Routine investigation was WBC 10400 and RBC 3.84, HB 12.2 grams, and platelets 2.36 lakh. Creat was 0.76. HbS H3 was negative. Pus culture was no growth. Psychosocial aspect of patient Kumar Pal, 54 years old, male married and had 2 children living his own house. He was not able to work since 2005. His wife is only earning person in his family, belongs to Christian family but lost faith in God. Medication was tab amoxicillin 625 mg TDS, tab vitamin C OD, tab amitriptyline 25 mg SHOD, tab tramadol 100 mg BD, injection PCM 900 mg QVT and syrup clemafin 10 ml SHOD, injection fortwin 30 mg PRN and injection finargan 25 mg PRN. Main concern was pressure sore, throbbing pain, loss of appetite, financial issue, loss of faith in God. Summary was patient 54 years old with hemiparesis with bed sore over right and left trochanteric region. Stage 4, conscious and having throbbing pain. He had fever continuously. He is on antibiotic analgesic getting tedious dressing with isol and normal saline. He is hospitalized for debridement and rehabilitation. He was started on high protein diet. He was started on physiotherapy. Sorry, patient prognosis was not good. He died on 8/3/2022. Discussion point. Does this patient need palliative care? Does this patient was his need anything else? What all problem he was facing? How we can counsel the family members? Thank you.
Thank you, Sister Sia, for the presentation. If anybody need any more clarification regarding the patient story, please ask them. So otherwise, we can move on to the discussion points.
I would like someone from amongst you itself to unmute yourself, or others. You can use your chat box to tell me that what are the points which is of concern in this patient. We have gone through the theoretical part of delirium. We had listed many causes in it. Can you identify and pinpoint some of the issues which is relevant for this patient, which can lead to a delirium? Okay, so there are somebody is telling, Shikha sister is telling financial problem, neuropathic pain, insomnia, metabolic causes. Okay, loss of faith in God, will it cause delirium? I'm not sure. Pain, yes. Physical impairment, very good. Insomnia, quality of life, immobility, severe pain, immobilization, and infection. Sister Salome has hit the nail on its head. So we are seeing that this patient is having severe pain. He is having, he is a hemiplegic right now. So he's having immobilization and he's having infection as well. Can we just have the previous slide? Come back. So here we can see that this patient is having a large pressure sore, right, over the trochanteric region extending to the back. That is one. Now, I hope all of you is aware that this is a wound. Basically, this is an ulcer and it is a wound, and it can get infected, right? And the infection can spread to deeper levels as well. So that is one source which can be a cause of delirium. Secondly, like sister said, that there is immobilization. We can see here left-sided hemiparesis and right-sided hemiparesis. That means there is weakness of the lower limbs, bilateral lower, both the sides are having weakness because of an old stroke which is there in this patient. And he is currently on bed rest. Now there are many factors which is coming in, right? One thing is the patient is immobile. And because of the immobility, he has developed a pressure sore. We don't know what is the care of the pressure sore. Is it being done well? Is there slough over it? Is there infection over it? We are not sure about it yet. Sister Sia, was there any, how was the pressure sore?
Sir, it was infected and
So yeah, and it was
done in hospitalized.
okay. So hospitalized patient with the infected pressure sore, right? Can we have the previous slide? Right. So here, can you identify a few other reasons which can be a cause for delirium from this slide? So you have already told about the pain. Chat box మాత్రమేనండి. Right? So constipation, insomnia. Sister Sia, what was done for constipation for this patient?
Sir, Limafin was given 10 ml SHOD.
Okay. Okay. So something was done for the constipation, you're saying, right? The patient was relieved of constipation. Hypotension, low BP causing low oxygenation. Yes, possible. Possible. So here we have a case which is having multiple factors, right? Multifactorial. If you look at the delirium cause, there are multiple causes which can be a contributing factor for delirium, right? Right, eyes and ears. Can we just have a look at the previous slide? How old was he? He's a 54-year-old. So 54-year-old would mean that he's a slightly elderly patient, right? He's elderly patient who is probably he's in a vulnerable state. So you remember we had looked at individual risk factors and triggering factors. So now he is a person whose individual risk factors are high, correct? He is a high individual risk factors. In such a person, even small triggers will be enough for him to go into delirium. So this is a person who is a candidate who needs to be taken care of. Multiple things needs to be taken care of for him so that he doesn't end up in delirium, right? So looking at his condition of the ulcer, okay, and constipation, the pain, we have looked at U. The U of delirium was uncontrolled pain. He is having severe throbbing pain, which needs to be looked at, characterized, and appropriate pain medication has to be given to him. So looks like despite of the pain medications which he is getting, he needs something higher or more stronger probably. Sister Sia, was his pain medications managed later on? What was done for it, or was he continuing on the same medication?
Continuous on the same medication, kept tramadol 100 mg BD.
Okay, so tramadol is going on. Okay, tramadol, and I think Phenergan also is going on. So these will be medications which the doctor's team has to look into with careful assessment that, is the pain getting controlled or not? Because that itself can be one thing which, if relieved, the person may be safe from going into delirium. Can we have the last slide? Okay, so what all are the problems which he is facing? Because we told about the all the physical aspects or the medical aspects of it, but definitely, like in the previous slide, it was shown that there are social aspects as well, which will always be. Yes, exactly. There is a loss of job. Can we look at the previous slide? Right. So financial, yeah, yeah. So he's married. He has 2 children. He is not able to work since 2005. I'm very sure that anybody who is having a family and not able to work, and putting all the responsibility goes to the wife. When such a thing happens, it is going to be extremely distressing for the patient. So here comes a place where there is a role for multidisciplinary approach. One thing is we need a social worker, correct? We need a social worker who can assess these things in detail and see what solutions can be made. Yes, there is an aspect of spiritual pain. The person has lost faith in God. So there is an existential crisis going on for the patient. Why this disease happened to me? How long will I be a burden for my family? Okay, will I ever be able to walk again, or will I ever be able to work again? Can I contribute in a meaningful way to my family? Will my children think that I am a useless person who is at home? This loss of existence or an existential crisis, something which is very real and which patients go through. So this is where we need a lot of psychosocial assessment which needs to be done, and some solution which needs to happen. One thing is, in the rehabilitation of the patient, is everything possible being done so that the ulcers can heal as quickly as possible? How bad is the hemiparesis? Will it improve with physiotherapy? Is it going to improve with physiotherapy? Is he actively doing physiotherapy? Are we able to provide that? Okay, if he is not having the money to take it from a hospital, are we able to connect him to some NGO or some local body like that, which for charity does this? Some voluntary organization which does this. Okay, so many aspects coming in, not just the physical factors, emotional and psychosocial factors, which is part of looking at the patient as a whole, right? We have always been saying from day one in palliative care that we are looking at total care, and total care means going beyond the physical symptoms which the person is having, which can cause distress to the patient. So here is a person who is having physical and psychosocial issues, who is having the risk factors for going into delirium, right? And can go into that at any point of time. And sister said that the person is having infection. It's an infected wound. So the wound care has to become optimized. Basically, we have to optimize. Maybe may have to take a surgery consultation as well and look at the wound and see if some debridement needs to be done. Debridement means whatever is the dead part in the ulcer needs to be removed or not, so as to assist the healing process as fast as possible. So is there anything else which anyone wants to contribute? Can we have the last slide? Any other aspect? So does this patient needs palliative care? Absolutely yes. A patient who is having ulcers will be on long term, will be bedridden in this kind of a scenario where he is having bilateral hemiparesis or weakness of the body of both sides. We have discussed all the problems which he is facing. This patient is in need of anything else? Definitely yes. One thing, medically, a lot of things needs to be settled for him. The pain, the infection, the wound needs to be taken care of, and physical rehabilitation needs to be taken care of, and counseling the family members. One is to ensure that with proper support, his healing process will become quicker. He will recover, the wounds will recover, and to ensure that we take some consultations which may be required, so that the family feels that we are not just settling for what we have, but we are trying to do actively as much as we can do. And once we assessing the patient and making him rehabilitate well with physiotherapy, hopefully one day we can give him a certain kind of a job or provide him with certain kind of employment, which can be looked at through some charitable organization or through a volunteer network, where it can give back meaning to the patient, that he is living with dignity. He is able to work and contribute for his wife and 2 children. This kind of a counseling will be required, and an approach will be required over a period of time. If there is anything else any of you want to contribute, we have a couple of minutes. You can unmute yourself, or you can use the chat box. Yes, Mahima sister, if the dressing is painful, we can use bupivacaine, soak in bupivacaine, and place it over the wound for a few minutes, and then go ahead with the dressing. So I think there is nothing else. So that's all from my side. Sister Sheba, over to you.
Thank you, Dr. Deepak, for the wonderful presentation. The case presentation also.
Ma'am, you are not clear.
There is some disturbance, I think, in the mic, Sister Ji.
No.
not audible?
It's not clear. I think you can try without the mic once, Sister Ji. I think there is some loose connection maybe.
Hello.
Yes, Sister Ji, now it's clear.
Clear? Yeah. Sorry. Thank you, Dr. Deepak, for the excellent presentation. And you have covered in the case presentation, you have covered all the aspects, especially physical aspects, social aspects, spiritual aspects, and emotional aspects too. Whenever we see a patients like this, you have to try to cover the almost all that you can try to cover the all the aspects as we have learned about in palliative care. That patients need total care. In coming to the delirium part, so as Dr. Deepak said, this is one of the very common symptoms which we have seen in palliative care. When a patient develop delirium, the main thing is the caregivers may think that this is madness. So it's our duty to tell the caregivers about this is not madness, and so why that symptom is developed, that what is the causes of delirium, that patient, that particular patient. So that needs very important. You have to convey that to the caregivers, and always try to treat the patient with the respect. Okay, whether the patient is able to listen your words or not, you have to give respect to the patient always. As sir said earlier, uh, try to identify the cause and correct the correctable cause. So if when a patient develop delirium, as a nurse, you have to find out whether there is any precipitating factor or predisposing factor, or that things you have to find out, because the distension of bladder, fecal infractions, hypoglycemia, hyperglycemia, these all hyponatremia, and also that unrelieved pain and restraints, using restraints, these all cause delirium. So we have to find out if these cause delirium, try to that manage that symptoms. Without a doctor, you have to treat that cause, because if the patient is having this distension of bladder, so you can put a that Foley's catheter, and also if the patient is having constipations, you can give an enema, or you can do a manual removal and try to relieve the constipation. That way we can able to relieve delirium. So after that, you can, if that non-pharmacological management is not help, you can think for a medical management. The drug of choice of delirium is haloperidol. And also we have learned on that opioid class. So one of the opioid toxicity is delirium. So always try to check the patient's medications too. If a patient start delirium, so you can check the medication history also. Thank you. I think time up, we can wind up the session. Once again, thank you, Dr. Deepak, for the excellent presentation. Sister Sia for the excellent case presentation. Thank you.
Thank you, Sister Ji. Thank you, everyone, for active participation as well. I hope you continue this fruitful learning process through the course. Thank you.
Thank you. Thank you. Bye.
Thank you all. I have shared the feedback link in the chat box and in your WhatsApp group. Kindly fill it up. I will see you on the next class. Bye.